Welcome to the Dr. Izzy's Medical Podcast channel.
Follicular lymphoma. Follicular lymphoma, FL, is a cancer that involves certain types of white blood cells known as lymphocytes. The cancer originates from the uncontrolled division of specific types of B cells known as centrocytes and centroblasts. These cells normally occupy the follicles in the germinal centers of lymphoid tissues such as lymph nodes. The cancerous cells in FL typically form follicular or follicle-like structures in the tissues they invade. These structures are usually the dominant histological feature of this cancer. There are several synonymous and obsolete terms for FL such as centroblastic and centrocytic lymphoma, nodular lymphoma, Brill-Simmer's disease, and the subtype designation, follicular large cell lymphoma. In the US and Europe, this disease is the second most common form of non-Hodgkin's lymphomas, exceeded only by diffuse large B-cell lymphoma. FL is a broad and extremely complex clinical entity with a wide range of manifestations which have not yet been fully systematized. It is commonly preceded by a benign precancerous disorder in which abnormal centrocytes and/or centroblasts accumulate in lymphoid tissue. They may then circulate in the blood to cause an asymptomatic condition termed in situ lymphoid neoplasia of the follicular lymphoma type. A small percentage of these cases progress to FL. Most commonly, however, FL presents as a swelling of lymph nodes in the neck, armpits, and/or groin. Less often, it presents as a gastrointestinal tract cancer, a cancer in children involving lymphoid tissues of the head and neck area, for example tonsils, or one or more masses in non-lymphoid tissues such as the testes. The serial progressions of in situ FL to FL and FL to TFL appear to involve the accumulation of increasing numbers of genomic alterations in the formative B-cell precursors to these disorders. At least some of these alterations appear to cause the overexpression or underexpression of the products of genes that regulate these cells' susceptibility to develop further genomic alterations, to survive, to proliferate, and/or to spread to other tissues. In consequence, multiple B-cell clones that exhibit increasing genomic alterations and malignant behaviors populate the disorder. No single genomic alteration seems responsible for the development of each of the spectrum of FL disorders. Rather, interactions between multiple genomic alterations appear to underlie this serial progression. Tumor environment. The non-neoplastic immune and stromal cells as well as the extracellular matrix in tissues may enable neoplastic follicular cells to survive, proliferate, and avoid surveillance by the immune system. For example, laboratory studies show that 1. Follicular dendritic cells, fibroblastic reticular cells, and T helper cells provide growth and survival signals to neoplastic follicular B cells. 2. Neoplastic follicular B cells recruit regulatory T cells that act to suppress immune responses to them. 3. The cytotoxic T cells which normally kill neoplastic cells become dysfunctional in the presence of neoplastic follicular cells that are embedded in this multicellular environment. And 4. Bone marrow stromal cells directly support the growth of neoplastic follicular cells. Reduced levels of immune infiltration has been shown to be strongly associated with early progression of disease. Diagnosis. Follicular lymphoma replacing a lymph node, the bubble-like outgrowths are enlarged follicles. The diagnosis of FL depends on examining involved tissues for histological, immunological, and chromosomal abnormalities that are indicative of the disease. FL usually involves enlarged lymph nodes populated by abnormal follicles that when examined histologically contain a mixture of centrocytes or centroblasts surrounded by non-malignant cells, mostly T cells. The centrocytes, which typically outnumber centroblasts, are small to medium-sized B-cell lymphocytes that characteristically exhibit cleaved nuclei. The centroblasts are larger B-cell lymphocytes without cleaved nuclei. Rare cases of FL may show lesions that contain tissue infiltrations dominated by B cells with features of precursor cells, monocytes, or malignant mantle cells such as those found in mantle cell lymphoma. Immunochemical analyses reveal that these cells generally express B-cell surface markers including the CD10, CD20, CD19, CD22, and CD79 but not CD5, CD11C, or CD23 cell surface proteins. Genomic analyses reveal that these cells contain T1418, Q32Q21.3, translocation, 1p36 deletions, and with far less frequency the other genomic abnormalities listed in the above sections on pathophysiology and presentation and course. None of these protein markers or genomic abnormalities are diagnostic for FL. For example, the T1418, Q32Q21.3, translocation is found in 30% of diffuse large B-cell lymphoma and in a small number of reactive benign lymph nodes. Rather, the diagnosis is made by a combination of histological, immunological, and genomic abnormalities. According to World Health Organization criteria, differences in the microscopically determined morphology of these tissues can be used to diagnose and categorized FL into the following 3 grades, with grade 3 having A and B subtypes. They are: Grade 1, follicles have less than 5 centroblasts per high power field. Grade 2, follicles have 6 to 15 centroblasts per high power field. Grade 3, follicles have greater than 15 centroblasts per high power field. Grade 3A, grade 3 in which the follicles contain predominantly centrocytes. Grade 3B, grade 3 in which the follicles consist almost entirely of centroblasts. Grades 1 and 2 are regarded as low-grade FL. Grade 3A is usually also regarded as low-grade FL, although some studies have regarded it as high-grade FL, and grade 3B is regarded as a highly aggressive FL in the TFL category. In addition to grade 3B disease, histologic examinations may reveal other evidence of TFL, such as histologic findings consistent with FL and diffuse large cell lymphoma in the same tissue or in separate tissues, or histologic findings similar to those found in Burkitt lymphoma, precursor B-cell lymphoblastic leukemia, plasmablastic lymphoma, the high-grade subtype of B-cell lymphoma, Hodgkin lymphoma of the B-cell type, chronic lymphocytic leukemia, small cell lymphocytic lymphoma, or histiocytic sarcoma. Other findings indicating the presence of this transformation include rapid growth in size of lymph nodes, recently acquired or new B symptoms, recent development of FL lesions in non-nodal tissue, rapid rises in serum lactate dehydrogenase levels, and the presence of high levels of serum calcium. Differential diagnosis. FL may be confused with marginal zone B-cell lymphoma, mantle cell lymphoma, and the small lymphocytic lymphoma variant of chronic lymphocytic leukemia. The malignant cells in marginal zone B-cell lymphoma may form follicular structures but commonly proliferate in the marginal zone rather than germinal center of lymphoid tissues. These malignant cells often show features of monocytes or plasma cells. Mantle cell lymphoma show monotonous, medium-sized lymphocytes, monocytes, and atrophied germinal centers. Unlike FL, the malignant lymphocytes in this disease are positive for cyclin D1 by immunohistochemistry staining. Small lymphocytic lymphomas are composed of nodular structures with small to medium-sized malignant cells surrounding immature lymphocytes and immunoblasts. The malignant cells in this disease, unlike FL, stain positive for CD5 and CD23. Treatment and prognosis in FL. FL is typically a slowly growing lymphoma with an overall median life expectancy for treated patients of 10 to 15 years, with many cases of it waxing and waning in the size of their lesions and rare cases of it remitting spontaneously. These considerations favor the use of observation over intervention in patients whose particular form of FL has a favorable prognosis or who are intolerant to aggressive treatments. However, most cases of FL have a less favorable prognosis at some stage of their disease and will therefore require intervention. There is little consensus regarding the guidelines to be used to define the prognosis and treatment for FL at its presentation or during its course. Currently used indicators for this include the diseases: 1. Histology, 2. Subtype, 3. Predicted indolence and potential for transformation, and 4. Extent of disease as measured by clinical examinations, bone marrow biopsy to determine bone marrow involvement, and PET-CT imaging of the chest, abdomen, pelvis, and any areas outside of these regions if physical examination suggests involvement. In situ follicular lymphoma. In situ follicular lymphoma is a benign condition that may be re-evaluated periodically to detect the rare cases of it which progress to FL. Otherwise, in situ follicular lymphoma is not treated. Localized follicular lymphoma. In 10 to 20% of cases, FL appears limited to single radiation field, does not involve the bone marrow, and is therefore regarded as localized early-stage FL. In these cases, which are sometimes classified as Ann Arbor Stage 1 or Stage 2, radiation therapy achieves 10-year overall survival rates of 60 to 80% and median overall survival times of 19 years. It seems likely that many of the relapses in these cases are due to undetected disease outside of the radiation field at the time of radiation treatment. The use of PET-CT imaging is strongly recommended to ensure that the FL is localized. In any case, the excellent results achieved with radiation therapy strongly support its use in localized disease. The use of an immunotherapeutic agent such as rituximab alone or in combination with a chemotherapeutic regimen such as CVP, that is cyclophosphamide, vincristine, prednisone and rituximab, in cases of localized, early-stage disease may be appropriate choices for some of these early-stage patients. However, the The latter approach is recommended for cases of localized disease in which the disease extends beyond a single field. 56% of patients treated in this manner had progression-free survival at 10 years, while patients treated with other regimens had progression-free survivals of 41%. Nonetheless, overall survival did not differ between the two groups. Asymptomatic follicular lymphoma. Patients with asymptomatic but not localized low-grade FL, gastrointestinal tract FL, and pediatric-type follicular lymphoma have been served by careful follow-up without therapeutic intervention. Even high-grade, aggressive, relapsed, or transformed FL may also be served with observation in patients who are asymptomatic. Findings in asymptomatic patients who have been recommended as triggers for starting treatment include one or more of the following: tumor size greater than or equal to 7 cm in diameter, involvement of greater than or equal to 3 nodes in 3 distinct areas, each of which is greater than or equal to 3 cm in diameter, organ compression, presence of ascites or pleural effusion, poor performance status due to the disease, elevated levels of serum lactose dehydrogenase or beta-2 microglobulin, presence of localized bone lesions, kidney involvement, reduced levels of circulating blood platelets or any of the various types of white blood cells, onset of significant pruritus or other B symptoms, and enlargement of lymph nodes, spleen, or other follicular lymphoma infiltrated organs or tissues. Symptomatic follicular lymphoma. Symptomatic FL requires treatments directed at relieving symptoms by reducing the load of tumor cells. Various chemotherapeutic regimens have been used for this, including combinations of alkylating anti-neoplastic agents, nucleoside analogues, and/or anthracyclines. Two commonly used chemotherapeutic regimens are CVP and CHOP, that is CVP plus the anthracycline adriamycin. Newer agents used to treat FL include monoclonal antibodies such as rituximab, obinutuzumab, galiximab, inotuzumab ozogamicin, or epertuzumab, and immunomodulators such as lenalidomide and interferon. The latter medications have been used in combination or alone to treat symptomatic FL. Most such regimens add rituximab with CVP or CHOP regimens, termed RCVP and RCHOP regimens. The RCHOP regimen appears superior to the RCVP regimen with, for example, one study finding 8-year progression-free survival rates of 57% versus 46% for the two respective regimens. More recently, FL patients have been treated with other regimens including 1. Rituximab combined with the chemotherapeutic alkylating agent bendamustine, 2. Rituximab combined with the chemotherapeutic agent fludarabine and the inhibitor of type 2 topoisomerase, mitoxantrone, and 3. Rituximab combined with another immunotherapeutic agent such as galiximab, epertuzumab, or the immunomodulating medication, lenalidomide. While it is too soon to judge the long-term results of the latter regimens, the regimens have shown similar results when analyzed based on poor treatment responses. Bendamustine with rituximab may be preferable to RCHOP or CVP for treating low-grade 3A, FL. RCHOP may be preferred in FL that has high-risk characteristics, for example high levels of beta-2 macroglobulin or bone marrow involvement. The combination of lenalidomide with rituximab has shown good potential in treating indolent cases of FL. Studies indicate that maintenance therapy with rituximab following successful induction therapy prolongs progression-free survival. For example, one study found progression-free survival after 6 years of treatment was 59.2% in patients treated with rituximab maintenance and 42.7% without this maintenance. However, overall survival at 6 years was similar in the two groups, 87.4% and 88.7%, respectively. Another study found that prolonged maintenance with rituximab did not have any benefits over an 8-month maintenance period. Finally, surgery and radiation are additional therapies that can be used to relieve symptoms caused by bulky TFL disease or to treat lesions in patients who cannot withstand other types of treatment. Transformed follicular lymphoma. Early studies on treating TFL with various purely chemotherapy regimens gave poor results with median overall survival times of 1 to 2 years. However, the addition of rituximab to the regimens such as CVP and CHOP as part of induction and maintenance therapies, that is our CVP and our CHOP, greatly improved overall 5-year survival to rates of 73%. The RCHOP regimen is a good option for treating such cases. However, these regimens need not be started in people with FL who are asymptomatic and have low tumor burdens. The outcomes in such patients show no difference between early versus delayed treatment. Some recent studies found that the use of rituximab in combination with bendamustine provided better results than RCHOP. Progression-free survival times in one study were 69.5 months for Airbay and 31.2 months for RCHOP. Similar results were obtained when Airbay was compared to our CVP. These studies also found no overall survival time benefit between the AIRBAY and R-CHOP regimens. Other recently examined regimens include 1. The use of obinutuzumab instead of rituximab in the R-CHOP and R-CVP regimens to attain progression-free survival rates at 3 years of 80% for the obinutuzumab chemotherapy regimen versus 73% for the rituximab chemotherapy regimen, and 2. The combination of rituximab with lenalidomide versus various chemotherapy plus immunotherapy to achieve similar complete remission and 3-year progression-free survival rates, but with rituximab plus lenalidomide causing less toxicity. Many of these studies did use rituximab maintenance therapy after induction therapy. Prevention. Several studies, while not conclusive, suggest that the early treatment of low-risk FL reduces the incidence of the disease progressing to TFL. The treatments used in these studies include chemotherapy, radiation therapy, and immunotherapy combinations plus rituximab maintenance therapy. Relapsed follicular lymphoma. Patients who relapse after initial therapy for FL may be followed closely without therapy if asymptomatic. When treatment is required, patients may be treated with the initial treatment regimen when such treatment led to a remission that lasted for at least 1 year, otherwise an alternative regimen is used. The regimens commonly used in relapsed lymphoma include R-CHOP, R-CVP, RFM, which is rituximab, fludarabine, and mitoxantrone, and bendamustine plus rituximab. Patients who suffer early treatment failure or multiple relapses have also been treated with either autologous or allogeneic stem cell bone marrow transplantation. While studies are inconclusive, autologous stem cell bone marrow transplantation appears to prolong survival in early treatment failure patients who are healthy enough to withstand this therapy. Unfit patients may benefit from initial treatment with obinutuzumab plus bendamustine followed by maintenance treatment with obinutuzumab, if they have not been treated previously with obinutuzumab. Other mostly experimental treatments currently under study in patients with multiple treatment failures include 1. Phosphoinositide 3 kinase inhibitors such as copanlisib, duvelisib, and idelalisib, which block the phosphoinositide 3 kinase signaling pathway that promotes the survival, proliferation, and other potentially malignant behaviors of cells. 2. Infusion of Tisangin-like cell chimeric antigen receptor T cells. 3. Bruton's tyrosine kinase inhibitor, ibrutinib, to block the B-cell maturating actions of this kinase. 4. BCL inhibitor venetoclax to block BCL2's action in promoting B-cell survival and proliferation. 5. Histone deacetylase inhibitors abexanostat and tazemetostat to modify the expression of various genes. And 6. Checkpoint inhibitors nivolumab, pitolisumab, and pembrolizumab to promote the immune system's ability to suppress cancer cell growth. In preliminary studies on FL patients who were known or thought to be refractory to more conventional therapies, these drugs, when combined with more conventional drugs, particularly rituximab, produced promising results.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.